now have Kellan Carrig here who will speak to us about physical therapy and sensory motor integration.
So, yeah, I waited to go to the bathroom for everything because I knew I was coming next, but now I'm kind of regretting that. But it's not the best introduction. So, my name is Kellan Carrig. I'm a physical therapist, pediatric at Perkins School for the Blind in Watertown. So, not too far away from here. I graduated from Northeastern University in 2007 with my doctorate in physical therapy. And I have a certification in neurodevelopmental treatment, which I just got in 2014. So, and basically what I want to talk about today, and I'm really happy to be here, so I was really excited to get an invitation to come and speak to you. This is something, ALD is something that is still new to me. It's something that I'm still looking for more information with. You know, I come here to learn as well. So I really like that you seem to have a community that is very open to having a dialogue, which is great. So if you have questions along the way, let me know. But also I'm hoping that you know, maybe I can offer something to somebody here that you can walk away and you have a little something to take with you, maybe a new avenue to explore, or something to think about. So there's paper that's being passed around now. When you get a piece of paper, if you can crumple it up and place it like in the back of your shirt, right behind your neck. And then we can get started. So, a little overview here. So today we're going to talk about processing sensory information, the sensory system and everyday life, how we use it in our everyday life. We're going to talk about sensory processing impairments, and sensory regulation and motor learning, which is really the PT aspect that I like to talk about. So first we need to talk about how do we process, First we have to talk about how do we process sensory information. So if you just have, usually I pass things around, but if you have an object nearby, just pick something up, hold it in your hand, and I just want you to think for a second, you know, how would you describe that object? Okay. So, and how do you know? And that's the really important piece about the sensory information is how do you know how you describe it? Now, I imagine most of you probably used your vision. You maybe thought about a color that this object was. You maybe thought about a shape that it looked like. Some of you also use touch, to hold it in your hand, to feel what it's like. I doubt anybody really smelled it. Usually, not too many people do that, or taste it for the most part, unless it's, you know, a cup of coffee or something like that. But if it's something like a piece of paper, you could hear everything crinkling, everything moving like that. So we're constantly using our senses to be able to determine what's happening in our environment and things in our environment, and to kind of figure out how we have a relationship with them. Other people would also say we have additional senses, which is the vestibular system, the proprioception. And proprioception is what's going to give you, you know, what's it going to feel like, is other than that tactile information, but how heavy is it? You know, is it firm? Is it soft? Is it smooth? It's going to give you a little bit more information about that. And the vestibular system kind of helps you orient your body to what's in your environment as well. So, self-regulation and routines. So what we're going to do to think about here is what do you do when you wake up? Because everybody has some kind of routine. Do you wake up, you know, how many people here wake up, the first thing they need to do is hit the snooze button? Okay, I'm definitely one of those people. Maybe even a couple times. And then there's another group of people that might hear the alarm go up and they're up, they're ready to go, they're ready to start the day, they're off to the gym. Some people need that first cup of coffee in the morning. Some people have a routine, they have to brush their teeth first before they take a shower. Sometimes for other people it's the other way around. And what do you do at the end of the day? What do you need to help bring yourself down, relax a little bit, and calm down after you've done something busy? But why do we do this? Why do we establish these routines? And the reason for that is really self-regulation. How would you feel if I told you you had to do things differently? How would you feel if I told you you had to shower at night before and not in the morning? Maybe sometimes that shower is what gets us up and gets us moving. So we all have our own sensory diets. And sensory input can be alerting to us. It can make us more aroused and ready for a certain aspect of our day, or it can be calming, it can bring us down and can put us a little, so it does have an effect over our mood. Daily activities provide us with input to keep us regulated, to be able to become more alert, relaxed, and a lot of times just be able to focus on the task or the job that you need to do. So this is probably my favorite slide. This is an example of when your engines run high. We use that a lot in pediatrics because it's a way for kids to be able to understand when they're feeling very energetic. So we talk about engines running high. I like to think that these two are probably married and maybe forgot to take the garbage out or something. But you can see these are examples of all different times in your life where you might feel energetic, your engines might be running high, you might be ready for a lot. You know, you get kind of flight or flight response. And then we have also times when you're feeling sick, when you're bored, if you're listening to somebody giving a really boring lecture, talking about slides. All different aspects in your day that you might get some lulls. So this is an example of typically where we would typically run, all right? It's between these points here for the most part, as far as our sensory regulation goes. So you might wake up in the morning here, you hear your alarm go off, and then you hit the snooze button, and then you kind of settle down a little bit. But you hear it go off again, and this time you really know you have to get up. So the next thing you're doing, you get your cup of coffee, and you really get riled up, which is nice. On the low arousal side, you know, we're constant, maybe the loudest things won't wake you up, that cup of coffee's not going to wake you up, and you're just kind of really low, and you really can't participate. You can't hold yourself up, you can't concentrate, you can't really focus on the task at hand that you need to do if you're at that lower level.
So sorry, Kellan, so this was 1991, before the time of Fitbit. How do you collect this data? How did they collect this data?
So this data was actually more recorded based on being able to self-report. I'm not sure exactly what the scale was, but through a questionnaire being able to report, you know, where your day is. But it's a kind of I think the biggest thing to take away from this too is just to see the variability from what we would consider normal from one person to the next.
Because in this day and age, we could do this with devices, right?
Yeah, and probably, you know, the Apple Watch is really, we're going to be able to get it more. We're going to be sent right to the doctor that way. So technology is going to be able to change a lot of the ways that we can collect this data, that we can be able to do it. It's, you know, this is going to be harder for kids that are going to be nonverbal to really get this report. So a lot of it has to be done, you know, clinically based on observation. How are they presenting when they come in? Are they bouncing? For kids with visual impairment, a lot of times you'll see that they'll do different hand movements or they'll do head movements and things like that. And you can kind of see they're ready to bounce or ready to move. Or they might come in and they might be a little bit more lethargic that day. And you can see it in their posture, you can see it in their expressions. So clinically, we might have to do that based on our observations. So I have a little visual processing game, just to give you an example of what it's like to have a visual impairment. So this is going to be something that you're really going to need to pay attention for. So we're going to get, I'm sure a lot of people sitting up a little taller right now, getting ready to pay attention, kind of getting on that higher state of your regulation. So there are going to be some directions that pop up pretty quick. So here we go. Couple hands starting to pop up. Give it a couple more seconds. Okay, so who wants to give me the answer?
The heart.
The heart. Very good. So for everyone who's like, what just happened? So basically, this is a game called Spotted. You can order it off Amazon. Amazon Prime, you probably have it in 2 days. Or pick it up at Target, I'm sure. So, but it's kind of a fun, it's kind of it's basically all visual, but basically there's an object on the left that matches an object on the right. And sometimes they throw you off because of the green dinosaur and the green shamrock. And a lot of times, the reason why this worked for some people and not others, for a lot of different reasons. One of them is because some people are attracted to different colors than other people. Red tends to be a color that stands out, especially for somebody with a visual impairment, cortical visual impairment, which is kind of a brain side vision issue rather than it being on the eye side. It's about how that information is being interpreted. So some people might have been attracted to red and saw the hearts right away. Other people might have missed the directions. other people might have not really known where to look because the background is really kind of confusing and it's hard to pick out what's going to be the most important information. So some people had a little bit easier time with this than others, which is completely normal, that's fine. Again, a lot of variation just in this room. So if we do this again, we can actually get a chance to read directions. There's nice contrast between the words in the background, and then it pops up. And let's see a show of hands when you guys get it. Okay, so I definitely see more hands this time, but it's interesting because some people brought their hands up much quicker last time than this time. So did anyone find this one harder? A couple people found this one harder, and that could be partly because you were maybe attracted to the red beforehand, where this one's a little bit more difficult. So what's the answer on this one?
Bottles.
The bottle. Good. Sometimes the contrast on this one is a little bit more difficult too, because the white of the bottle kind of blends in with the background a little bit more, and you're attracted to the other colors first. But that's what it's like when you have a visual impairment, and especially if you're not at the right state of arousal. And somebody gives you direction or gives you a complex background. Even me looking at everybody here, if I'm looking at one of you, there's a complex background. There's people sitting with different color shirts, different patterns. I have to ignore everything else to focus on that one person that I'm talking to, or that one thing that I'm trying to focus on, and shut everything else out. So for the kids that have a problem or an impairment with their ability to sense this information or gather this information or interpret this information, they're not able to, if they're running really high on that chart, they're not able to distinguish what's the important information. And if they can't distinguish what's the important information, then they're not going to be able to learn. They're not going to be able to learn on a cognitive level. They're not going to be able to learn on a motor level. So how's the paper? Did anybody forget about it? How many people it was driving you crazy that entire time and you could barely pay attention to what I was saying? So again, fluctuation, you can take it out now. How many people just had to take it out? Some people had to take it out before we even got there, which is fine. Again, that goes back to a lot of fluctuation, a lot of variability from one person to the next. But if you're one of those kids, or if you're a person that has that heightened response all the time, little things are going to bother you like that. We can go throughout the day, we can go out through the day, you put your pants on in the morning and you realize you put pants on, but then you walk throughout the day and you don't feel those pants anymore, right? They're still there, thank goodness, but you don't feel them anymore. And that's a good thing, because if you just felt your pants all day long, that'd be the only thing that you were thinking about. But your mind shuts all that out so you can focus on what's going to be most important. A lot of our kids can't do that. Because they can't find that right state of regulation. So that's why they don't like tags. That's why they don't like certain textures. That's why they can't wear certain items of clothing, some things that are too tight. They might like baggier clothing. It really makes a big difference for them, and it really affects their education. So signs of sensory processing disorder is either an increased response to this type of stimuli or a decreased response to that type of stimuli. Typically you find that these kids are easily distracted, they have difficulty with transitions, and really inability to attend to a task. So sensory processing disorder really means that your nervous system is unable to take in all the sensory information and figure out what's going to be the most important. You can't maintain that proper level of arousal to be able to participate or learn. You're going to be very defensive to certain things. A lot of kids will either crave the things that they miss, or they want nothing to do with the things that they're not getting. And when you throw in a visual impairment on top of that, which tends to link with ALD because there tends to be breakdown in myelization and white matter, and a lot of the time that happens in the back of the brain where a lot of the vision is being processed. So visual impairments with ALD, this becomes significant. It can also happen to do with decreased body awareness, not knowing where your body is, not knowing where upright is. So how can you sit up and focus on a task if your body's down here and you don't know that you're up in midline? The visual system really drives a lot our posture in a lot of ways. So if you start messing with the visual system and you don't have very good awareness of where your body is, it's really going to affect your posture. It's going to potentially long-term, affect, create muscle imbalances that you're going to have secondary complication or impairments from. And like I say again, and I'll bring this up several times, decreased learning on the cognitive and motor side. And the cognitive, I think of like, math skills all in your head, and the motor side, how to execute a skill. So sensory diet. So occupational therapy this is really their realm. They're going to be the ones to look at this information, come up with sensory diets, and identify these impairments. They can help give you a sensory diet, so something that they can give students or a child to carry out through without their day, or use in times that they really feel they need it. But it's really something that, it's an individualized program, and the occupational therapists are going to be the ones to do that. So you're probably thinking, then why am I listening to a PT? And the reason for that is because it's important. It's important for what we do. So we do a lot of consult with occupational therapy, so we can make sure we get the most updated information and get that information about the child that we're working with. And the big thing is that we need to get the children that we work with in a state that they can learn. And to do that, we're better off starting, maybe even if it takes a couple minutes in the beginning of our treatments, 5-10 minutes, starting with that, getting them in the right state of arousal so we can work with them. And then we get better motor outcomes from it. Sometimes we can just do it at the beginning of the session. Sometimes we need to kind of continue it, and the best way to do it is to be able to combine it with the gross motor activities that we're performing. So we try to incorporate the activities that address the student's sensory needs, as well as works on their physical impairments and functional limitations. So we try to combine a lot of activities from the sensory and the motor side. So a lot of movement. So like a swing would be an example of that. A swing will give a lot of vestibular movement, so a lot of moving back and forth. You can work in different planes depending on the type of swing. There are a lot of different swings out there. But you can also work on gross motor activities, pushing off of surfaces, pumping your legs to swing. There are handheld swings that you can push off of to use. So we're getting a gross motor component in it as well. But it really teaches the kids and allows them to be active in their sensory learning. These are some other examples that are really good for sensory motor activities that are really good for children that have any type of sensory processing issues. Yoga is fantastic. You get a lot of bang for your buck. When you're doing weight-bearing activities through your hands and your legs, you're getting a lot of proprioception, meaning that you're getting information about where your body is, and related to its environment and related to other body parts. You're getting vestibular input because you're doing a lot of changing positions. Your ear has three different canals that are all oriented differently, so it's important to change positions on your side, on your back, with your face down, sitting, to be able to work all of those areas. You get kinesthetic awareness, which is similar to proprioception, that it's about knowing where your body is. You get stretching and lengthening of muscles, you get strengthening. You can work on breathing, which is really important as well. Group games can also work on auditory processing, following directions, and having peer interactions. Obstacle courses, what it's like to move your body over things, underneath things, maybe getting squeezed by something as you go through it. And different pieces of sensory equipment like swings, bouncers, spinners, weighted objects, objects that allow kids to get some compression that really tends to increase their body awareness. So overall, this is just kind of a quick recap of what we're talking is that we all use sensory strategies. We don't really think about it through our day because it's just so ingrained in what we do, but we all use them, and we use things to keep us alert, to calm us down, to keep us focused and attentive at work. But kids' jobs are really to play. That's what they're meant to do. That's how they develop, that's how they grow, and that's how they learn new skills. So kids are also developing new baselines every day. This is not a rehab type situation where you're trying to get somebody back to a point where they were before necessarily. When you're working with children, they're learning new skills all the time. They're not relearning, they're learning for the first time. So it's not a rehab setting, it's a habitual setting. And it's something that you have to keep in mind, that they need exposure to as many different things, gross motor skills, sensory activities, especially if they have these impairments, because they're gonna be less likely to seek it out themselves. And impaired sensory processing complicates learning, the cognitive and motor aspect. So when you learn something new, your body has to take in the sensory information. It has to get to your brain. Your brain has to figure out what it is, determine what's appropriate to look at and what's okay to throw away, interpret that information, come up with a plan of how do we react to it, and then send that signal back out, and then you have to execute some kind of skill how you're going to react to it. So if the information, the sensory side, is coming in wrong, we can't expect the output to be accurate either. So it's really important that we get the sensory aspect of gross motor skills and learning. It's really important that we focus on the sensory aspect so we can give a better expectation of what the outcome is going to be. So, any questions? That's a lot of information.
One thing I always tell my patients is, if you don't use it, you lose it, right?
Very true.
And that's really important to have physical therapy. So I brought Josh out here because he hates physical therapy. Okay. So
I've heard that before.
I thought, what a great combo here.
It's just a big waste of time, right?
So maybe I thought he would tell his story.
Yeah, start with telling us how you diagnosed yourself with
Well,
ADD.
I'll start quickly with Addisons, and then we'll just quickly move on because I actually might have to go to the bathroom. But anyway, so I was up at Penn State in 1999. I was getting my biology, BS in biology, and I was walking normal. Everything was fine. And then one day I was walking down the hill from Penn State to go to my apartment. And there's a lot of people walking up past me and by me, and as I was going down the hill, I felt like I was going to fall over. So I basically just stopped and kneeled down. I was just pretending to tie my shoe because I didn't know what was going on. A lot of students walking up and past me, and I stood back up and I took a step and everything was different. It wasn't extreme, it was just like my feet weren't placing where they should have been and so forth. So I went to physical therapy because I thought, actually I didn't talk about Addisons, but I thought taking all the steroids was like messing with my cartilage, and I didn't know what was going on. But let's jump quickly before that. I was 19, I just turned 19, I was emaciated, I was getting sick, and I was taken to the hospital, and they diagnosed me with Addisons. But the most amazing thing that I realized out of that whole situation was, during the time when I was with my grandparents in New Jersey, I was eating cup of soup after cup of soup after cup of soup after cup of soup. And I just thought I liked them a lot. I had no idea that my brain was protecting my body by saying, take in more salt, take in more salt. And obviously with Addison's disease, we have issues with salt regulation that follows with water balance and all that. Anyway, so I got the Addison's. 2 years later, I'm up at Penn State, and that happens with the walking. And from then on, everything just slowly started getting different and different. I met my ex-wife up there, and I had walking difficulties, but she didn't notice it. But I did. I noticed it. I noticed every step, which was interesting. So basically, I've been living with AMN for about 16 years, and it went from me just kind of not having the best walking to a wheelchair in 2011. I walked with a cane a little bit from that point. I walked a little bit with 2 canes, and then I was like, this is so hard. I can't do this anymore. I need to have a better way, something that's safer, because I fell a lot. I broke 2 ribs by falling. So now I use my wheelchair 100% of the time when I go out. When I'm in the house, I have a scooter. And that makes me more mobile. I can go anywhere with the scooter. I can go around the block with the scooter. I can go check the mail. I can go on grass. So, I mean, for me, this whole situation is all about adapting. And if you can't adapt to your situation, what's going to happen?
So Josh, tell the story. How you
Oh, yeah. I forgot about it. Okay, so 1999, I had that issue with the walking. And I had seen Lorenzo's Oil in high school. And I really liked the movie. I was always into science ever since I was like 5. Biology, the body, I loved all that stuff. So I remembered that movie for some reason, and I wanted to watch it with my dad. So we were in his bedroom, we were watching it, and we got to a point when they diagnosed Lorenzo with adrenoleukodystrophy. And as soon as I heard that, adreno? So we stopped the movie, we got online in 1999, and within an hour I diagnosed myself with AMN. After that, we went to Kennedy Krieger to get the plasma very long chain fatty acid test, and of course, it was spot on. So yeah, I mean, it's hard. It's not easy, but I tell everybody this: I would rather have the disability than the Addisons disease, because Addisons is horrible. I wake up tired. I'm tired throughout the day. I'll feel nauseous. Blah blah blah. But I did pursue my master's in nutrition at UF because I wanted to learn more about how nutrients affect your body and everything about that. So ever since then, I've been, I'm a very healthy eater, drink tons of water, eat lots of fruit, and that helps with the Addisons because it gives me a nice balance of energy. I mean, imagine eating sweets all day long. You rock it up and then you crash and you feel tired, and that's not what I wanted to feel. So, when you get sick, you learn a lot. And when you learn a lot, you could talk to other people about what you've learned, and, maybe it can help them with anything. Not just AMN, it could be diabetes, it could be, cancer, it could be any other type of disease. So I'm kind of thankful that I did get sick because it caused me to go on this path in my life of learning and exploring and researching and all that stuff. I mean, ultimately, I would rather be normal. I have 3 kids, so the disease never stopped me from doing that, which is great because my kids are amazing and I love them so much. But that's pretty much it.
No, that's great. So I think that deserves a round of applause.
Thank you.
So I want to start a little dialogue here, okay? Let's shake this up here. Starting to sweat. So Josh hates physical therapy, right? I mean, that's right. So you have a physical therapist.
But why? Why do you hate it?
Physical terrorist, I've heard before.
Because it's a lot of work and I don't think it's going to help. That's why.
So first question, if beyond himself doing it, is there any value in passive stretching movement? I told him to get his kids to start moving his legs.
Nah. Actually, when my legs would bother me when they were little, I said, "Hey, stand on my legs. Just stand on them. Just walk all over them." Because one of the biggest problems. I don't have this anymore because I take Seroquel sleeping med. I would be up for hours with cramps in my legs. I'd be folding them. I'd be trying to get in all these types of positions to relieve it, and it's horrible. And now I only have it like once every couple months, thank God, because it really was torture. I mean, I would literally sit in bed. I would punch my legs until they hurt because I was trying to distract that stiffness with pain. I'd rather have the pain than the stiffness.
Okay, good upper extremity.
So this is really interesting, and the things that I heard you talk about.
Yeah.
How difficult it was to walk, how difficult it was to be able to use those crutches to go. So one of the reasons that I liked physical therapy and the reason that I got into it is because and there were different paths of medicine that I could have looked into, but physical therapy was about function, and function is what allows you to participate socially and within a community and with other people. And if you don't have that participation level, function is meaningless. Who cares if you can put on your socks and shoes if you can't go to somebody and walk to them and see them. So it's about that participation piece, which is really the most meaningful, and that's really what I hear from you. You want to be able to engage with your family, with your friends. You want to be able, and it's better for you to be able to get in a scooter, you know, and go around the block if that's what you need to do. And I understand that every time, you know, we as humans are built to walk upright. We're built to move. We're built to walk. That's what we're meant to do. Every time that we add a walker, every time that you add crutches, you're changing the way we're biomechanically meant to work. And energy consumption, every time you go through that process, the more and more need that you need, energy consumption goes through the roof. I mean, it takes so much more effort to go such a smaller amount of space,
and that
smaller distance.
I agree, and that was the problem, because everything took so much energy, and then I had the Addisons, so it was like a double negative.
Right.
And it was hard.
Yeah. So great, you can get up and you walk on crutches, but if it makes you feel terrible,
exactly,
and it's hard to do, I understand the frustration with that.
Yeah.
You know, with that said, you know, we have to find something that works for you, that works for the individual, that we can find a way that they're going to be able to best access their community, their friends, and what's going to be most important to them. Now, at the same time, as a PT, I still have to advocate long muscles or strong muscles. You know, that over time, you know, that stiffness in your legs can lead to other things. And then it's not necessarily just going to be the stiffness anymore. It could be contractures. It could be changes in your posture.
Spasms.
It can, the spasms. All of those things can eventually lead to other things. So there's other ways that, you know, we need to be proactive in preventing those type of things from taking over as well.
I hear you. One way I thought of getting PT without doing PT was when I was doing physical therapy. When I first noticed this going on, they put electrodes on my muscles and stimulated. I mean, to me, that seems like the best way. Get a machine at home, stimulate your muscles for 30 minutes a day.
That seems like a good infomercial. I think everybody wants that.
I don't know. I thought it was a good idea.
But there's a time and a place for that, you know, in therapy and rehab when that's useful. But you know, it's not necessarily going to give you that gain.
I know.
I had a patient travel from South Africa to come see me here, and his recipe was he kept these bees in a jar, and he had these bees sting his legs that weren't moving.
Of course.
And for him, this was the ultimate stimulation. So we're not recommending this for the camera.
I've heard of that. Yeah, the bee venom.
Correct me. Or as physical therapist, what do you say to that?
That's not something I've prescribed yet. I have to go back to the evidence-based approach and see if we have the evidence for that one yet. But
good. So thanks to both for being a good sport.
But you have to kill the bees every time you do it.
That's not fair. That was the conclusion. Sorry, question?
Yeah.
Sanjay?
So could you tell us a little bit more about the symptoms of the Addisons and what made that so bad?
I mean, I think the first and foremost problem with seeing this happen was not feeling normal, not feeling confident to go out. I didn't want people to see me walk like that. So I would, you know, when I would walk it up at Penn State, I would focus on kicking my legs out every time I walked and all that. And that was like the first slight. You know, as it got harder, my legs got stiffer, weaker. I mean, that's pretty much it.
What about the Addisons?
What about it?
Why is that? Why'd you say that's worse?
Because it is. I throw up. Emergency room.
Yeah.
If I'm alone, I mean, I have my medical order, but that's not the same. My dad usually injects the cortisone. I'll tell him I'm sick, and it makes you feel really vulnerable. So, you know, I mean, for me, yeah, keeping your immune system up to par is extremely important with Addisons, because you don't want to get to that point where you need to go in an ambulance where they wheel you out of your house, then you're stuck in the hospital for 5 hours, and all you need is fluids anyway. So it's not like they're doing that much for you. But I can't handle stress. Even with the steroids, I still feel like there's Addisons with me. And I do. I wake up tired. I'm tired throughout the day. I feel nauseous. I don't want to eat breakfast, but I have to because I'm hungry. You know what I mean? Like it's a really horrible situation. It really is. I think it's more complicated than the AMN.
So this actually validates what we found on our patient portal first survey, where to our surprise, I mean,
But we didn't know.
we
So
didn't.
you don't realize how much you're giving right now at your first meeting ever.
Oh, okay. Well, I'm glad to give it to you.
The accidental hero. So, but we'll move on now to Julie Howard. Thanks so much for being a sport.
Thank you.